Hello class, this is Dr. Turpin. I'm going to record our CVA lecture. Please listen to it prior to the class on this coming Thursday. We will be doing an active exercise in class, and therefore, we'll cover some of the content with that activity, but I want to make sure that you get the full information a little bit ahead of time so that you'll have the CVA key points for our tests that will be upcoming. You may hear this term TIA. Some people will call this a mini stroke. The term is trans ischemic attack. It is considered kind of a warning sign of an impending stroke. It occurs when you have a brief interruption of cerebral blood flow. You can have a lot of the typical symptoms that you see with a full-on stroke. But again, it's transient, meaning that they may have blurred vision or double vision or some sensory deficits, experience some numbness or even some speech deficits or inability to speak for a short period of time. But then it's transient, so it comes and has those symptoms and then it goes. So some patients will have these. One of our key problems with stroke care is that patients do not recognize the signs and symptoms, and they may have these brief type of attacks that later then lead to a full-on stroke, and they didn't seek attention. And we're going to see some of the hours and times that are absolutely required for the different types of treatment for stroke. And so one of the key important things that we as nurses can do is to educate patients about the symptoms of stroke so that they seek emergent care very quickly so that they are even eligible for the treatments that may improve the blood flow and not cause necrosis and tissue death. So I just bring that up and we'll talk a little bit more about that, but TIAs are often a warning symptom, so letting them know that some of these things can occur and then just resolve. Most patients, if you have a little something happen to you but it resolves, you kind of think, well, I don't need to go to the doctor, I'm okay now. And so that in this case is likely not good advice. So what is a stroke and how is that different? It is an onset of an acute neurological deficit that persists more than 24 hours, and it's caused, again, by the interruption of blood flow to the brain. So it is a functional abnormality of the central nervous system because it is occurring in the brain, and it happens when the blood flow, of course, is disrupted. Stroke statistics, a stroke occurs every 40 seconds. So this is why, again, it's such a widespread problem, and of course, stroke, the narrowing of vessels that we have talked about with other chronic diseases that play into the high risk for stroke, make so many Americans more susceptible to this disease. And you can see that we're seeing about 795,000 are diagnosed with a stroke every year. And these type of strokes, and I know you've seen some of these patients, it's one of the leading cause of disability for older patients. And so prevention of these or getting treatment as quick as possible to minimize the long-term disability is absolutely key interventions for nurses to take seriously. People need to think of this as a true attack of the brain, just like we think of a heart attack as an attack of the heart. It warrants the same degree of emergency, and you have to think, like we would say, the amount of time is heart muscle in terms of damage to the heart from ischemia, and therefore, ongoing pacing and rhythm issues or pump issues because of dead tissue with the heart. The same thing is true with brain and brain function, and central nervous system effects down to the peripheral nervous system. So time is brain. Treatment options are most effective if administered within the first 3 hours after experiencing symptoms. So again, we go back to the TIA. If you're starting to have symptoms, but it kind of resolves, and then 6 hours later you start to have a few more symptoms and it gets worse, some treatments, and you'll see on the algorithm that's provided here in a little bit, why that makes them no longer a candidate for some therapies that really can help improve the flow. There is a lot of evidence that lets us know that early treatment is really what improves the reductions in permanent disability. In the U.S., it takes most people anywhere from 12 to 24 hours to get to the hospital. And this is why it's really important they need to really recognize and know how to respond. So most of your older patients, that go home that have, VTE or DVT education because of surgeries, because of heart disease or whatever that's made them at risk for blood clots, really need to get also discharge education about the signs and symptoms of a potential stroke, because they can follow, periods of immobility because of, a DVT that's traveled. And so trying to tie that again to get more and more education out to older people about these symptoms. And so they recognize, don't come in the car, go, call EMS and get somebody there immediately, because again, you think about some of the rural areas that we are around in terms of providing care in North Carolina. Some places you can't, get ready, drive, navigate, and then get into a local ER that's a trauma center for has a stroke center for this type of disability without getting airlifted somewhere. So, trying to get somebody to a stroke center is very important, because they're accustomed to, doing all this stuff in a very timelined manner. So these are some of the types of stroke to be aware of. You see on your syllabus and on your outline for your course schedule that we really talk about the difference between ischemic stroke and hemorrhagic stroke. So ischemic stroke can either be thrombotic or embolic, and hemorrhagic stroke is, instead of a circulation collapse because of a clot or a blockage, a hemorrhagic stroke is where you have an aneurysm in the brain bleed, you have severe hypertension that is pressing down on vessels and causing ischemia. Or you can have what's called an arteriovenous malformation that can create a weak area that bleeding can occur. And so, hemorrhagic strokes, it's important to really know what you're dealing with when you get a stroke patient, because some of the treatments for ischemic stroke, as you can imagine, are to give, anticoagulant therapy to open up and open up the vessels so that it's no longer ischemic, and or to kind of prevent further clots from being thrown and further stroke potential. And if you have somebody who already has a hemorrhage going on in their brain, the last thing that you're going to want to treat with is an anticoagulant. So that's why the early diagnostic phase, when someone comes in with stroke symptoms, is all about how do you make the decision, is it ischemic or is it hemorrhagic, so you can apply the appropriate therapy. So these are all the risk factors that you see for stroke, previous stroke or TIA. If they, of course, have arteriosclerosis or atherosclerosis or hyperlipidemia, which we've already covered last semester. We also learned when we talked about cardiac that atrial fibrillation may lead to blood clot formation that gets flecked out from the heart and then can travel up to the brain. Hypertension puts a person at risk for this, and quite honestly, one of the key vital signs findings in the middle of someone having a stroke is you will often see very, very high blood pressures when they come in. Smoking, diabetes, sedentary lifestyle, obesity, those are all common things that are creating risk factors for vessel disease, as we've already learned. And then use of oral contraceptives is associated with development of blood clots, and so in that way it makes it a risk factor. There are some patients that have coagulation disorders where they have more hyper coagulation type situations, and so they're at much more risk. Substance abuse, particularly cocaine, and alcohol abuse can be associated with development of clots, decreased circulation, sickle cell disease that we already learned about. There's clumping of the red blood cells that can lead to that as well. There also is race, age, ethnicity, and some genetic familial tendencies towards strokes. And then, although that's spelled wrong, it needs to be brain trauma. Obviously, from what we've mentioned in terms of, bleeding in the brain, can come from trauma, and then that can lead to an injury, can actually lead to the person having a stroke after the injury, because of intracranial pressure. This is just a little bit of stats on gender and strokes. Stroke kills more than twice as many American women every year as breast cancer. More women than men die from stroke, and the risk is higher for women due to a higher life expectancy. Women tend to take oral contraceptives for several years. Women suffer greater disability after stroke than men, and then women ages 45 to 54 are experiencing a stroke surge, mainly due to increased risk factors and really lack of prevention knowledge. So, you often used to think about men having a lot of strokes because of stress and high pressure jobs or physically demanding things that just made them at high risk, whereas more and more we're seeing that women are getting into a much higher risk factor than ever before. This is a little detail on race and strokes. You can just kind of see that African Americans are affected almost double that of Caucasians, and they're twice as likely to die from a stroke. So these are some real issues in terms of health disparities between ethnic and racial backgrounds. And then there are, of course, high incidence of risk factors that go along with that. For Hispanics, there's a higher incidence for Mexican Americans, and even to have TIAs and strokes at much earlier ages than Caucasians. And Spanish-speaking Hispanics are less likely to know stroke symptoms than folks that are English-speaking, somewhat because of the lack of knowledge initially, but also health literacy issues and the issues related to lack of teaching in their language. So if you do have a Hispanic patient that's getting that same discharge education, you need to be very sure to print off the information in their own language so that you can and get a translator to go over it, because it's very important that they get equal care. These are some of the clinical symptoms that manifestations: sudden and severe headache, trouble seeing in one or both eyes, sudden dizziness, trouble walking, sudden confusion, trouble speaking, and numbness or weakness of the face, arm,